Welcome to this morning's Thyroid Tumor Board from Tyro. As usual, this is our hourly meeting once a month where we review some wonderful cases and have a wonderful panel discussion. This morning, before we start, we wanted to pay tribute to a couple of our friends and colleagues that have passed over the last few months. And so to start with, we invited Dr. Baloche to come and share some words about Dr. Levolsi. Subaran?
Thank you for inviting me, Mike. This is something that it's hard, but I think it's also important for me to. I'm actually honored that you asked me to do that. So, you know, I knew of Dr. Levolsi when I was at Memorial, and Dr. Rozai often talked about her. So whenever we talked about thyroid, we talked about Dr. Levolsi and her criteria of explaining things. And he always told me that when you get a case which has been signed by Dr. Levolsi, before you disagree with her, ask me first, because I don't want to get killed on a next meeting. I want to stay alive. And when I came to Penn, and I became her mentee, and to this day, I stayed as her mentee. She was an amazing colleague. She was friends and a teacher to many of us, not just in pathology, but as you all know on this call, that you knew of Dr. Levolsi when you talked about thyroid. And it was not just thyroid, she was from a generation of pathologists who basically can look at any pathology and give you a differential and sign it out. So for us, it was really amazing. I'm being a little selfish here and sharing this because this is from one of our favorite cities, which is Rome, which always had this Italian thyroid meeting that was held at University of Rome. And the best part of it that we went to Vatican, and she was also a very devout Catholic. So when we went to these things, she will like show me things. And so it was not just thyroid. And everybody has these stories to really talk about her. And I think it will be very hard of us, but we're going to try our best to really maintain her legacy of the mentorship, teacher, and a friend. And I can only say few things that what I knew after being her mentee and working with her, that I really came to realize that the mentorship and friendship lasts forever. Because when I'm signing out cases now, I hear her in my back and basically telling me, you know, or discussing a case with me. So I think I personally, as long as I have this strength, I will go on thinking about these issues of mentorship and friendship and teaching. So it's a great loss, but I think it's kind of devastated to most of us. But we want to continue her legacy and really have her name shine, because I think it has to continue on for generations to come in pathology. So thank you so much for giving me this time.
Thank you, Subaran. Yeah, truly an amazing lady. When everybody else in this panel knows Virginia as well as all the pathologists, I think that's telling you something. She understood the clinical aspects of it and crossing over. One of my favorite things was to say something and look down the panel and see Virginia shaking her head, knowing that in 5 minutes she was going to tell me why I was wrong, and she was always right. We also had the passing in December of last year of Brian McIver. Brian and I first met in 1997, last century. I wish that's a joke, but it's not. 1997, at the American Thyroid Association meeting, when as very junior faculty, both of us showed up in the meeting room to do our first oral presentations to what would become our home for the next 25 years in the American Thyroid Association. That evening, Brian and I went out to celebrate, and he introduced me to something called Scotch, which was very different than my Kentucky bourbon. And to this day, I think it's the only thing Brian and I could never agree on. We reached consensus on everything else, but we just had to disagree that Scotch and bourbon were not the same. Brian worked obviously for many years at the Mayo Clinic. We know him as an educator and a teacher and a gifted speaker. Really a phenomenal person that ran panels, a phenomenal person that brought all the different specialties together to try to understand what everybody was doing, worked on American Thyroid Association guidelines, on NCCN. And to me, Brian was always the one that either challenged the status quo, why are we doing what we're doing? Or when we would try to change things, he would say, now, are we certain we're ready to change that? Have you thought about this? And I can tell you personally, a lot of the discussions we had with him went right back to our clinic and our research group, and we answered questions that he raised to make sure things were done the proper way. So Brian really had a phenomenal gift of understanding, a phenomenal person, always a phenomenal smile. He could completely disagree with me and still smile. And at the end of the day, we were still friends and helped each other and learned. So he will be missed, and I'm sure the Moffitt team will be putting together meetings and things in his honor, just like the group at UPenn will for Virginia. So if you don't mind, let's have just a moment of silence for both of them as we think about them and their families. Very good. Thank you very much. Well, I can't think of a better thing to do in their honor to participate in a panel and case discussion, which is what they were the best at doing of anybody that we know. All right, so let's introduce our panelists. We'll just go around the corner as we're going here, starting Dr. Cunningham.
Good morning. Great loss, just giants in our field. Thank you guys for doing that. That was beautiful. I am a surgeon, so I am the section head of endocrine surgery at Mass General. Do research using microsimulation modeling for thyroid cancer, have done some translational research. And do you want to keep introducing, or do you want me to just go ahead and as we're going?
I'll keep going. Dr. Wirth?
Morning, everyone. I second Carrie's comments on what a beautiful memory that is of both Brian and Virginia. I'm Lori Wirth. I'm a medical oncologist at Mass General in Boston.
Dr. Pasieka?
Janice Pasieka. I'm a endocrine surgeon in Calgary, Alberta.
Fantastic. Dr. Robenshtok?
Hi, I'm Eyal Robenshtok. I'm an endocrinologist and thyroid cancer specialist from Israel.
Dr. Brandwein?
Hi, I'm a pathologist. I'm chief of pathology at Mount Sinai West. I'm a director of a head and neck pathology fellowship, and I'm partners in crime with Mark.
That's a disclosure, a disclaimer. I'm not sure.
It sums it up. It sums it up.
Dr. Langer?
Hi, good morning. I'm a radiologist. I'm the ultrasound section chief at the University of Pennsylvania.
Okay, and I don't see Kate on here. We're good. Dr. Ghesani?
Hi, good morning, everyone. I am the chief of nuclear medicine at Mount Sinai Health System, and also partner in crime for imaging side with Mark.
Perfect. Dr. Alexander, if you have any disclosures regarding Dr. Erkin, you should share those, but introduce yourself and then let's start with the first case.
That would be a long list that I'd have to disclose. I'm Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital up in Boston, and happy to start on the first case here. Excellent. I'm going to keep us on time as well. I know we got two other great cases ahead and time moves quickly. It's a pleasure to present to you a case that I thought taught me a lot and had me reflect on a few things, share it with all of you. This is an 18-year-old female who's referred for a thyroid nodule. She's completely healthy, active. She's a senior in high school, and it was just a routine physical exam, a wellness check, where her pediatrician actually noticed the nodule, and she has no family history of thyroid problems, let alone thyroid cancer, and also the usual questions, no childhood radiation or symptoms of concern. She was completely healthy and not worried about this at all. To keep us moving, obviously, I think most people, when you would have a nodule suspected, would pursue an ultrasound, and I'm just going to cut to the chase on that. This is the report of the ultrasound, which, as you see, shows several small nodules, roughly 10 to 15 millimeters, and generally classified TIRADs 3 and 4, and notably no abnormal lymph nodes. And the first teaching point for me a little bit was the questions I posed at the bottom of the slide, which increasingly, I've been a bit more tuned to this question of how to think about age as a risk factor for thyroid cancer. But I'll throw that out to Eyal maybe a little bit, which is there really a meaningful difference in overall risk when you think of a nodule in a younger person than an older person, however you want to define those terms? And then also, do we think about, cancer risk at all differently, whether it's one or whether it's multiple? So maybe Eyal, I'll toss it to you for a second.
Yeah, so I think the answer is yes and yes. With age, healthy people have more and more nodules, and the risk per nodule decreases. So most people after the age of 60 or 70 have nodules. A younger patient, like this one, 18 years old, the risk of malignancy in a nodule is as high as 30%, as opposed to an older patient where it's down to 5%. So yeah, so this is suspicious already by just existing, even before we see the ultrasound features. And multiple macroscopic nodules are also uncommon, because many times we have multifocal disease, we have one dominant nodule and several small ones. So when we see a younger patient with several macroscopic lesions, we need to think whether it's part of a syndrome. Does she have a genetic tendency for malignancy?
No, well said, Eyal, and I agree, and I'll go very briefly, but I'm always drawn to these data. Nora Kwong was one of our fellows now a decade ago or so, and clearly, at least in our data set here in Boston, there's a clear age-related decline in risk as you age forward, but the younger individual, I do worry about a little bit more, just average entering a nodule workup, that they have a higher risk. And as you quoted, Eyal, Ari Wasser's data on the pediatric population clearly shows that line continuing. So I also just throw out that, we should think about, I think, pediatric or younger adult nodules and cancers also driven likely by different processes. And there's a wealth of data thinking about the different mutations. These are earlier data. It's not as in-depth as we likely would genetically screen now, but for the sake of time, I'll move on. Jill, I'm going to pull you in on two questions, which is, I know this is just one image on a PowerPoint, but is this a TIRADS 4? And also in particular, can I throw one of my questions out, which is, I don't like it when either the kind of anterior surface of the gland is pushed forward like this, even if the nodule's not taller than wider, but that could just be my own neurosis a little bit. Can you comment a little on what you see?
Sure. Yeah, a couple of quick things, and I think the most important point of all is that really TIRADs should not be used in a pediatric population as it is applied to adults. And the data is showing, is just as we've all said, the risk of cancer per nodule is much higher in children. That said, it is important for radiologists to sort of harmonize their reporting in a standard that is uniform, that makes sense. So on one hand, I would say, yes, this is a suspicious nodule. It's hypoechoic, it's solid. The overlying capsule on this one image seems to be intact. It may have no choice other than to bulge it because it's in the isthmus. But that said, the isthmus also has a little bit of a statistically higher likelihood of cancer in all comers. So certainly would need an FNA.
Absolutely. And that's what we did. And it did return positive for papillary carcinoma. And obviously the next step here would be, I think, surgical resection. For the sake of time, I'm not going to go into how much surgery and whatnot for instead focusing us on what I think was a little bit different. So I was surprised when this is what returned, which is a Cribriform Morular Thyroid Carcinoma. And maybe Zubair, to you, what is this and how is this different? Is this a thyroid cancer, and where to begin, I guess, on this?
Sure. By Zubair, you mean Margie. And
Margie. Sorry.
All right. I go by many names, as long as you don't call me Mrs. Levy. Can you go to the next slide, please?
I can.
Oh, no. You had some pictures there. Didn't you? Here we go. My old friend, Cribriform Morular. Okay, so let's go to figure A. One of the notable things on low power Cribriform Morular is, where's the colloid, right? You're seeing some kind of like thyroid cancer, and if this were a routine, follicular variant, routine papillary, you would see colloid in there, and that's something that you don't see. When I was reviewing these slides, one of the things that you should look for, and it's probably in slide A if you magnified it, but just leave it for the moment, is when you have follicles that are back to back, instead of having two layers of follicular cells, you have what's described as a bar, a single layer of follicular cells. So the follicles are devoid of colloid, which is a very funny look. They're very expanded, and in many places you can see a bar of single cell follicular cells between the two follicles. Now in the next, let's see, in B, let's jump to C. In C, in the very center, you see a morula formation. So a morula is just kind of squamoid, but not really keratinizing, a kind of round knot of squamoid cells. And so those are the two features that I just described, the big empty wide spaces, that's cribriform, and then the squamoid balls, that's the morula. Now those are not the only findings, but those are the two findings for the name. Now, it's been said, so from time and time again, I will see PTC that has morula formation, but no cribriforming. And that's actually been associated with the RET PTC translocation. So that's kind of an interesting thing. Now, let's go to D. And in D, we see the papillae formation. These papillae are not really, they don't look like the normal classical PTC papillae. They're thicker, they're fatter. They look maybe a little bit more like misshapen chorionic villi. And, chorionic villi are going to be these big kind of, mucinous thing, myxoid kind of centers. These are kind of, they're squished up, but they don't look normal. They're not thin and filigree. Now, if you look at the cells of Cribriform morula, the nuclei don't quite make it for a typical PTC. I mean, there's no doubt this is PTC, but if you really look at it critically, they look a little bit different. So the whole thing with Cribriform morula PTC is that it's one of these rare occasions where the pathologist can be just a hero, right? Yeah. Because this can be predictive of FAP, familial adenomatoid polyposis, and a pathologist can, with that diagnosis, just set a whole chain reaction, going forward of, investigating the patient, investigating the family, et cetera, et cetera. The last thing I want to say is, I have read, though I haven't seen it, that although this association is, this is significantly associated with FAP, the increased risk of PTC with FAP is not limited to this morphology. I've never encountered that I know a PTC associated with FAP that looks just routine, although I've read that you could see that. And that's the moment.
No, and for those who haven't, seen this, and I certainly, it's pretty rare when it walks through the door up here, but it was formerly a variant of papillary carcinoma. Now it's its own designation. As Margie went through many of these issues, it doesn't express thyroglobulin, and it's driven by a different pathway, and you can see the rare incidence. So it's a unique find, if you will, and one that is quite different. This was her pathology, which showed basically the highlight of what I had said earlier, 1.4 centimeter cribriform morular without lymph nodes, without other high-risk features. But the questions I had, just to keep us moving forward, that I asked myself at the time were these, which is really, what is the risk of this unique carcinoma? And do you think about it similarly as you would to papillary carcinoma, low, intermediate, high risk? And in that regard, what do you think about radioiodine, especially in a younger person? A big issue is, how are you going to follow this patient? I'll come back to that. And as Margie went through the separate association. So time is short for my case, but I am going to pitch Mike the first one, which is, do you think about this one differently, Mike, than you would a follicular variant, a classical variant of papillary?
Yeah, actually, I don't. Other than the association with FAP, these seem to behave just like classic papillaries. When you were talking, I'm trying to remember if I ever saw one with distant mets or aggressive. I don't think I have. They've generally been 30-year-olds, 20-year-olds. Surgeries worked very well. So I don't have a huge experience to know, like, if the TGs go up when they get bad, because these have generally behaved very well.
And I presume then I'm going to put you on the second question. 1.4 centimeter intrathyroidal lesion, would you give radioiodine?
I'd give them the option of not doing that, but follow that post-op thyroglobulin. I'd want to make sure somebody good did an ultrasound that we weren't missing some lymph node metastasis, but these guys don't generally have TG positive antibodies. So as long as the TG looked good, the post-op thyroglobulin, perfectly happy to watch her without radioactive iodine.
That's exactly what I did. And I was reassured by a thyroglobulin, I don't know, less than 1, very low. But then I was reading on it and I realized it doesn't really produce thyroglobulin. So Eyal, to you, was that a false reassurance? And also, how do you follow the patient forward if you don't give radioiodine?
So just to say about radioiodine, I would decide after genetic counseling, because if she has genetic propensity for other cancers that might be life-threatening, I would not give radioiodine. And thyroglobulin is not produced by the tumor. So the fact that we have undetectable thyroglobulin means there's no remnant of the normal thyroid, but it doesn't tell us what the disease status is. So I would do a neck ultrasound and maybe once a PET CT, just to be sure, because I don't have a tool to have a whole body, what's going on in the rest of the body outside the neck.
Yeah, and that was really awareness to me. I always assume thyroglobulin is pretty darn good unless it gets really de-differentiated, but I hadn't really thought about it in this field. So, you know, very quickly, what had been said, there's not a lot in the literature, but what is out there has tried to look broadly at what's been published. And this data by Lamb, I think, is one of the best kind of meta-analyses of what are usually case reports. And they compared here the Cribriform Morulars to the conventional papillaries you see in this grid. And you see it's almost purely a female-driven disease, much more so than even papillary, but it's generally low risk. You don't see a lot of lymph node metastases. You don't see a high mortality rate. It behaves akin to a low-risk papillary carcinoma. And that was kind of the way I took it after I looked in the literature, is what all the experts here said, that it's similar but different, if you will. And I did not give radioactive iodine. But of course, as Margie mentioned, its association with familial colorectal cancer syndromes, in particular FAP, is really the key. And it arises in about half of the cases and is linked to FAP about half the time. So importantly, not all of the time, but interestingly, then I thought to myself, I'd be a good internist and go back to the patient and just ask for a family history, right? And I did, and there was no signs of any symptoms that the patient had of concern. She was also 18, and also the family had no colorectal cancer at all. Not only that, strangely enough, as happens in this day, about 8 years ago, they had whole genome sequencing of both of their genomes, the parents did. And so they went back and looked, and there was no other abnormal mutation in FAP. So ironically, I felt a little reassured I was going to get the genetic testing, but I at least thought that the family history was reassuring, right? But I will take you forward to this. I did not know, but when you do look into Cribriform Morular Carcinoma and ask whether it ends up being sporadic or whether it ends up being associated with FAP, probably the biggest tip-off is the multifocality. And of course, looking back at her case, that's exactly what she had, is multiple nodules. And so I know I'm rushing forward a lot on this just to keep us on time, but unfortunately she did return as a de novo case, an index case, if you will, of a positive APC mutation. And for me, a very interesting case I wanted to share with you. So Mike, I'll turn it over for any other questions you might want to pose. And I know we have 2 other great cases here.
Yeah, perfect. No, I think it's a nice case. I mean, Eyal's initial comments, 18-year-old, multiple nodules, multifocal papillary, even though not knowing what familial thing, raising that issue, because you can see other familial syndromes as well and cancers in young people. So I think that's a good take-home point. Very good. Okay, Carrie, let's go to your case.
Oh,
Number
I'm
2.
sorry. Hey, Mike, can I ask one quick question
Sure,
of the panel? So, you know, I think we've all drank the Kool-Aid on not biopsying small, incidentally noted thyroid nodules. So how how do you look at thyroid nodules in pediatrics and young adults differently? And has there been a trend towards not biopsying small nodules in the younger patient population that might be not well founded?
Eyal?
So I think we do think about it a bit differently, because if we think something looks suspicious, let's say 7-8 millimeter in a 20-year-old woman. We know that micro-PTC tends to grow more in younger patients as compared to older patients. So again, younger patients with micro-PTC have a 30% risk of growth, and over 60 years old, again, low risk. So I think we'll be more inclined to do FNA even in smaller lesions. But we follow the guidelines, but we tend to be more liberal in younger patients. Use the ATA guidelines and not the TIRAD guidelines, and then it's more more FNA.
Yeah, very little experience watching little stuff in kids. So I think you have to be careful applying the older stuff to the kids. But to be fair, I've got folks in their early 20s we're following with observation, and they're pretty close there. Okay, Carrie, let's do yours.
Good morning, everyone, and thank you for letting me slip in here. So I'm gonna talk about a woman, a middle-aged woman, 56, female, who presented with a palpable thyroid nodule, and she discussed she had presented to the weight center, so no symptoms from the nodule, but she just was found on incidentally on exam. She had some hypothyroidism. And some primary hypertension that we were having a little bit of difficulty, or her Dr. Copeland, her endocrinologist, having a little trouble taking care of. So she's on some thyroid hormone, and so Cytomel and LT4. She was on our favorite Ozempic, which is, I was going to look up the number of people in the United States who are currently taking that, but just something to keep in mind. And Lodipine, metformin, excuse me, and she was requiring a little bit of insulin from time to time. She's married, one healthy son, no family history, except for a paternal grandmother with breast cancer. Her blood pressure is in the 140s or 160s. And as I said, left upper lobe thyroid nodule that was palpated. Here are the ultrasound images. Interestingly, kind of looked like the image that Dr. Alexander looked at almost in the isthmus or wherever close by. And I agree that when the overlying strap muscles are, this one you can see very clearly that there is a border, but usually in the operating room when this happens, I usually take a little bit of the muscle when it's this close. So this is the thyroid ultrasound, which identified a TIRADS 3 in the right lobe and a TIRADS 4 in the left. I'm a surgeon, so I'm gonna keep it very simple. So just a reminder for those watching, TIRADS 3, we usually wait until patients have nodules greater than 2.5 centimeters and TIRAD 4 greater than 1.5. So this patient just met criteria for that, the one on the left to be biopsied. And I realize I do not have the cytology on here anymore. I apologize when I changed my slides. Cytology revealed a follicular neoplasm of undetermined significance, I believe, with some Hürthle cells noted. So this was therefore sent for Afirma genetic testing and was found to be suspicious and MTC positive, which was a surprise both for all of us and the patient. So following this, the patient underwent some testing. Obviously, calcitonin was pretty high. CEA was 32, also pretty high for a tumor that small. Calcium was normal, and we want to make sure in any patient with MTC that we are evaluating all of the other things that could come from either a somatic or hereditary mutation in RET leading to MEN. She had plasma metanephrines, especially given her difficulties with her blood pressure control. Calcium was normal, PTH slightly elevated, which again, all of these things were kind of close, having the symptoms, and PTH a little bit elevated. But she did undergo RET sequencing, which was negative. So I operated on this woman just recently. So all that I have so far is her PACU PTH, which is good that it's not too high and not too low. I'm more worried about not too low in the PACU because when we do central lymph node dissections, those inferior parathyroids are frequently at risk. So I almost always, interestingly, just an aside with younger patients, I find that many of them also have lymph node metastasis with their papillaries. And so my threshold for doing a central lymph node dissection in those patients is much lower. And so similarly, medullary thyroid carcinoma in the United States, we typically do a total thyroidectomy and central lymph node dissection with or without obvious nodes on ultrasound and lateral compartments if they are concerning by ultrasound. So and in Europe, as many of us here know, that is different. Those are slightly different, and it's under debate whether or not to do the lateral compartments. So my usual strategy is to do the central and the total and see where the biomarkers come down to, and then if needed later on to do the lateral compartments. So this patient underwent, I always do an on-table ultrasound. And I did note, unfortunately, abnormal left paratracheal node. It's a perfect time to do the ultrasound. The patient's neck is really extended and they're asleep. And so I really think that's the best time to do it. I did not note any lateral compartment lymphadenopathy. So she underwent a total thyroidectomy, bilateral central lymph node dissection. And I do use nerve monitoring every time. So this is her pathology report. She had 2 foci of tumor, no C-cell hyperplasia that was noted in the small print below, just so you know. The left upper lobe, which is correlating with the ultrasound and biopsy that I previously shown, up to 1.8 centimeters. So it was a little larger than an ultrasound, and usually in the pathology specimen, a little smaller. So I think it had grown a little bit. Positive for medullary, which we expected. And another small focus in the lower pole of the same lobe. I got 22 nodes, so happy with that sort of harvest, knowing that I got enough of those central lymph node compartment to know that I did sort of a decent job of clearing it out. 3 of those nodes were involved. As I said, that one was rather large. It was up to, I believe it was the lymph node itself was 1.4 centimeters, but the metastatic deposit was 0.4. And no extra nodal extension was identified. So one thing that the first question that I would have is, I thought about this as I was working on this case, and I know we talk a lot about extranodal extension in terms of lymph node metastasis and really determining this micro versus macro metastatic disease. And for the folks in the on the panel, do you feel the same way about this with medullary thyroid carcinoma that we feel about it with papillary thyroid carcinoma and follicular?
Margie, you want to take that because you've kind of led this extranodal extension story.
Yeah, it's something that it's a topic that I love to hate. You know, there's definitions, you know, and the definitions include, you know, it could be out. Cancer could be out in the fact. You can see the cancer can basically kind of destroy the shape of the lymph node so that it deviates from what you would expect as a normal lymph node. Mm-hmm. Now, on the other hand, you very frequently see a sort of round, you know, roundish conglomerate of metastatic cancer that's expanding the lymph node. There's a lot of like fibrosis around it, and that's a question. You know, you can't, or I don't really call that kind of stuff extranodal extension. It's a containment of a metastasis, even though you no longer see the capsule of the lymph node. So I think it's kind of controversial. When you see E&E in small metastases, it's very clear what's going on. When you have these large metastases that coalescent, the radiologist will call them E&E. Well, then I'm kind of hard pressed because, you know, histologically I can't really confirm that it's E&E, but it makes sense that it is E&E. So I will tell you, it's a difficult topic. I feel very comfortable when it comes to to calling small metastases E&E. I could, put my life on the line for that. For large metastases, not.
Yeah, Janice, let me bring you in on this. The 22 lymph nodes from a prophylactic neck dissection. I mean, somebody taught Carrie to do this really, really well. One, that's a lot more lymph nodes than I see. And then number two, if the average surgeon is trying to go after 22 lymph nodes, are we going to do more harm than good? Because we're happy we found 3 lymph nodes, but they were 4 millimeters. So how do I make that balance, Janice?
Yeah, I mean, I think yes, you're right. 22 lymph nodes from the central compartment. That is a very completed central lymph node and dissection. And so kudos to Dr. Cunningham. This is a challenge. And I know that there's been studies looking at deviating away from a bilateral central compartment to sort of doing a 3/4, so unilateral, and then the whole pretracheal area, so 2/3 of the central compartment. And all of this is really focusing on making sure that we have good parathyroid function at the end of this. So really a lot of the strategy is, I'm sure Carrie can comment that if you've got your superior parathyroids well protected, you can be a little bit more aggressive inferior. But if you haven't seen those and you're struggling with parathyroid, you've got to be careful about a real good clearance, particularly in a prophylactic setting. Hypoparathyroidism is a bad disease.
Yeah. Before Carrie goes on, Erik, let me bring you one in. Jose Dominguez, a good friend, said, would this make the case for doing a calcitonin in all these nodules if we didn't have fancy molecular testing, but then there's the cost of the calcitonin and false positives. So in your thyroid nodule clinic, how are you using calcitonin to help sort out these nodules?
It's so funny that you brought that up. That was perfect. So this is something that I'm using my microsimulation model to assess, is whether on a population scale we should be doing calcitonin screening, or should we be using fine needle aspiration washouts for these. And so currently, if there's any, for me, when I see things that are Hürthle cell, and suspicious for, if I see calcifications looking at the ultrasound, I may send them. Obviously, I'm at Mass General, and our thyroid unit really does a great job of working up patients. So most of the time I leave it up to them before they're referred to me. So I normally see them after they have medullary. But for sure, at least all of our patients are sent for genetic testing once they have a medullary diagnosed. The debate is still on whether or not doing calcitonin screening on a large scale basis for all nodules, maybe even nodules smaller than a centimeter that we're not going to biopsy, right? Just to make sure that at least they don't have some flagrantly elevated calcitonin. So I do want to just mention, this is looking at the accuracy at FNA and diagnosing MTC. It's not great, right? So this was, I believe, 50% of patients. This is a large scale, obviously medullary is much less common. And this is just showing that these are looking at patients who had a final surgical pathological diagnosis of MTC and looking back at what their FNA pathology cytology looked like. So not great. And one of the issues is that I love when I put up pathology slides and then try to describe them. So please interrupt me, Dr. Baloch, or whoever wants to interrupt me. But it's tough, right? So these are 2 images, and I bet most of the non-pathologists don't know which 2 of these are Hürthle cell and which 2 of these are medullary. So I'm going to show you these here. So look at
I'll share a line from Yuri Nikiforov from many years ago. He said that medullary thyroid carcinoma is like the melanoma of the thyroid.
Interesting.
It can, look like anything, right? That's the take.
Right.
The great mimic. Yeah.
Right.
So I just want you to look at these here. Okay. And then side by side. Okay. So these, I'm not going to describe this, but if you look in the upper right, this is sort of how it looks on cytology. And I imagine that, the bottom right, there's some eccentric nucleoli, etc. I'm not going to try to describe these, that would be silly, but the ones on the left are NPCs and those on the right are those that are peripheral cell neoplasms, and at least to my eye, they look pretty similar. So it's not easy, is what I will say. The next thing I want to look a little bit at is the head-to-head comparison of calcitonin measurement of FNA washouts. So these are patients who maybe instead of saving or an additional specimen for molecular testing, i.e. meaning Afirma, ThyroSeq, or any other platform, sending it for a serologic, mixing it with some saline and sending it off for calcitonin, which, excuse me, is quite honestly a lot less expensive than the other. So it is overall, the sensitivity is much, much higher. So upwards in the 90s. So just something to think about. And maybe this is something we can all comment on a little bit. And then this is just looking again at how good these are. So looking at those that have, in comparison to the serum markers, when the calcitonin is less than 100 in the aspiration washout, it is very highly sensitive and specific for this. So really, it looks pretty good as a thought to do this. And then and maybe there we can talk. Maybe if someone wants to comment a little about if they're using this at all, and is it as good as it sounds?
Erik, any experience with this? I mean, you probably have the biggest nodule clinic out of all of us here.
We find medullary to be just much rarer in the US than in the European series. And so I don't have as much experience on this. I think, Carrie, you explained the literature really well.
Yeah, and Eyal, what sort of your perspective on this?
So we do washout if we have a suspicious lymph node, but not to diagnose the initial nodule. If we do have a nodule like this one with Hürtel cells, with no PTC cells, then we would check in the blood calcitonin. I just want to say something about the pathology. You asked about the pathology, how good we are in prognosticating medullary. So we're not good. In papillary thyroid carcinoma, we know each histological feature, give it a number and say what's the risk of recurrence. In medullary, we really look at calcitonin and doubling time. So we can have the same pathology like this, and then it's gonna have low calcitonin and stable forever. And we can have the same pathology and calcitonin doubling time of like 6 or 8 months, and then it goes badly. So it gives us just the first step, but we need to wait for calcitonin and for the dynamic. Good.
Carrie, let's go to your last topic.
Sure. I just wanted to mention this because, right, this is what a lot of our patients are coming and talking about. So Ozempic, and you can see here, right, you see the commercials and everything else that there's a concern for do not use Ozempic if you've ever had MTC. And as you noted, my patient was taking Ozempic. So of course she said, oh my gosh, this caused my tumor. Well, so then I said, I actually hadn't looked up the data and I thought it was important to do so. So I thought I would just mention it here, that indeed the adjusted odds ratio for cancer with Ozempic, and this was in a very large series actually, was upwards of the odds ratio of 1.7. So, and I believe this is not just medullary, this is all different types of thyroid cancer, but just something to keep in mind when your patients are on that.
Eyal, what's your take on that literature?
So I looked at many of these studies, not all of them. I think most of it is detection bias, because you go see an endocrinologist and they worry about your thyroid, they do an ultrasound, and then you have thyroid cancer. So I think it's mostly detection bias, and it's almost impossible to tell apart detection bias than real.
Sure. How long has Ozempic been on the market? Yeah. How long has it been on the market? I mean, we'd have to come up with some kind of latency period before we even talk about,
this class of drug. Yeah, the class of drugs has been on for about 10 years. There's been a couple of papers now that suggested there was an increase in thyroid cancer. It was significant enough that the EMA, the European group, like our FDA, looked at this back in October and said there's no signal here, that you can't rule one out. but because of selection bias, that's why they were seeing not only an increase in medullary, but an increase in the papillary. So the paper was published in the diabetes literature, so you'll hear that a lot. But right now, at least the main organizations say probably no direct effect that we can pull apart from just screening and detection. Okay, I'm going to move us along. I'm going to carry those were great topics to talk about. Lori, you've got a couple of topics and a very interesting case and a young lady. So take us through that.
Okay, I'm going to take us home. Disclosures. All right, so this is a patient of ours here at Mass General. She was diagnosed, she first presented in 2017 and was diagnosed with sporadic medullary thyroid carcinoma. She had surgery here showing T3N1B M0 disease. She was diagnosed in 2016. And just to summarize for pathology briefly, she had a 2.5 centimeter medullary thyroid carcinoma with extrathyroidal extension, LVI, positive margins. It was positive for calcitonin and CEA by immunohistochemistry. There were numerous lymph nodes that were seen. And there were several other micro MTCs in the remaining gland. She did have germline RET testing that was negative. And postoperatively, her calcitonin was 181 and CEA 15.7. So in January of 2017, just a few months after her initial surgery, she had a new right upper neck mass and underwent a revision neck surgery. There were 4 of 9 nodes that were involved. The largest was 3.2 centimeters with extranodal extension. No evidence of distant mets on a staging evaluation. And then she developed 4 new palpable right neck masses over the next few months, including in the right supraclavicular fossa overlying the head of the supraclavicular head. She had a PET CT at the time that showed uptake in multiple nodal stations. And the largest node was 1.6 centimeters. Her calcitonin was 270 and the CEA was 17.1. So she was—
Pause for just a second, Lori.
Yeah.
So as Eyal was saying, this lady is clearly doing something unusual, right? We see lots of people with lymph nodes, lots of people with N1B disease, but the number that grow back in 6 months, 8 months, so she's already declaring something different. Munir, any other imaging? I mean, we do PET CT and often it's not as positive as I would expect in medullary. Other imaging we should think about that would help us, because this lady's headed down a bad pathway here.
Yeah, so, it's typical, some of the recommendations and difference, we are talking about differences in the guidelines in the European versus American. First of all, if it's FDG PET CT, they only get detected if they are dedifferentiated and very aggressive with a high mitotic rate. For more differentiated MTC, the FDG PET CT oftentimes is false negative. So then becomes a question of how do you do the molecular specific imaging? And in Europe, there is quite a bit of experience with F-DOPA imaging. And so F-DOPA PET CT is readily recommended in the European literature. And that's because it's available readily. In the US, F-DOPA was approved a few years ago, but only for the Parkinson's disease in the early diagnosis. So as a result, if you look at the ATA guidelines, if you look at the NCCN, they all go to gallium dotatate imaging. And those are generally more sensitive in most of the MTCs other than very advanced dedifferentiated aggressive tumors. And the guidelines typically say that if it is more than 150 calcitonin, this is more so for the follow-up, and on the doubling time of less than 2 years, then you should consider, but that's your generally gallium dotatate. But yeah, FDG PET CT is generally not very good in most of these.
Yeah. All right, Lori, so take us through the case and you're teaching.
Yeah,
this
let me
work
ask
there.
Munir one more question about the gallium dotatate PET CT. So the liver, of course, lights up like mad with the gallium dotatate PET CT. And often in these, these patients can often have miliary metastases in the liver. So can you, is a gallium dotatate PET CT sensitive enough to detect liver disease, even though there's a lot of uptake in the liver? Or should we be coupling it with a good liver focused imaging as well, like MRI or CT?
Yeah. So typically what we do is when we read these, we scale our display intensity at various levels. So when you're looking for the rest of the body, you want to scale it differently compared to looking at the liver. So you can, even though these may be small, many of them have such a high expression of somatostatin that you can see them incrementally higher intensity than liver based on dynamically scaling the display window. And if you have completely negative, as you said, many of these are miliary, and that becomes an issue with all imaging modalities, whether it's DOPA, F-DOPA, whether it's gallium dotatate, or whether it's FDG. Whenever there are miliary, we miss across the board in molecular imaging, but because they have such a high degree of signal expression, many of them, even when they're small, we see them. So what we typically do is scale the intensity of the liver. If we see that, the specificity is extremely high. If we don't see it and you still have a suspicion, then as you said, Lori, we can then do the MRI of the liver.
Great, thank you.
Yeah.
Okay, so this patient clearly needs NGS testing of the tumor to look for targetable alterations. However, she also needs therapy, and this was in April of 2017. So she was started on cabozantinib. She was restaged after being on cabozantinib for 2 months. She had hypertension, mild diarrhea, mild nausea, hoarseness, and her hair turned white on cabozantinib. And then her CTs showed a mixed response. So there was regression of a couple of cervical nodes, but there was a new 1 centimeter right supraclavicular node. Her calcitonin and CEA did drop. And on NGS testing, a somatic RET M918T mutation was found. She remained on cabozantinib because we didn't have too many other good options at that point, and then we continued restaging every 2 months. So at 8 months on cabozantinib, again, she had the AEs. She had developed hand-foot syndrome by this time. Nonetheless, she was working full-time as a teacher and she was planning her wedding. And then CT scans after 8 months on cabozantinib showed significant progression that you can see here. So there's some just nasty looking disease here on the CT scans. Her calcitonin and CEA had gone up at that time as well. And here I just show an image of the RET protein, and in RET M918T mutations are in the kinase domain. They're the most common sporadic mutation that we encounter, and typically are associated with more aggressive disease. So that was just about when we had opened the Libretto 001 trial investigating selpercatinib. She was enrolled in the highest dose level of the dose escalation part of the study at 240 milligrams twice a day. This kinome dendrogram shows the selpercatinib, so it shows it's very, very highly specific and potent for RET with very little off-target kinase inhibition. You can see with those red dots there. So she started selpercatinib in March of 2018, and you can see her baseline calcitonin and CEA levels. So this shows her RECIST tumor measurements. After being on the study for just a couple of months, you can see she had a very nice partial response with decrease in some of the longest diameters by 51%. And you can see here her calcitonin and CEA levels dropped very nicely while she was on study as well. And she had no adverse events, even though she was on the highest dose level that was examined. So all of her hair pigmentation turned back to normal, no hypertension, no hand-foot syndrome, no nothing. This just shows the updated data from the Libretto 001 trial that was presented at the Japanese Thyroid Association meeting recently, showing very deep responses in the majority of patients with RET mutated medullary thyroid cancer, whether they had been previously treated with cabozantinib and or vandetanib or cabozantinib vandetanib naive. The objective response rate for previously treated patients was 73% and 82% for treatment naive patients. And we see the bars are color coded for the various mutations here. You can see responses across all of the various mutations that were enrolled in the trial.
We got about 3 minutes before our hard stop, Lori.
So, yeah,
my
pager is confirming that. So this shows the duration of response and progression-free survival in the previously treated and untreated patient populations. So very durable responses are seen as well. And this tornado plot here shows how well patients in general do. There are some toxicities, they're generally mild. So getting back to our patient, she got married, she remained on selpercatinib. She had a very long, durable partial response. Here's June of 2018, for example. She had a baby boy by surrogacy. We're getting into 2022. She achieved a complete response radiographically on selpercatinib. So everything was just going beautifully. We really got into a groove. In February of 2024, her son is 1.5 years old at this point. I saw her in clinic and palpated a new right neck mass. So we did a workup and found that she had a solitary recurrent right supraclavicular node that you can see here, 1.4 centimeters. Again, it just is a nasty looking node. It looks like it's got extranodal extension radiographically. And you can see here that her calcitonin and CEA levels had completely normalized on selpercatinib and stayed that way for a long time. With this recurrence, all of a sudden, the calcitonin level has bumped up a little bit. So what are we doing? She is undergoing a revision neck surgery again in a couple of weeks. And we do plan to do molecular diagnostics for this oligoprogressive disease. I just wanted to show this very quickly. We're learning a lot about acquired resistance mechanisms to the RET inhibitors. We're seeing solvent front mutations that block the drug binding into the kinase receptor. But unfortunately, we're also seeing a number of other alterations. There are a number of on-target RET acquired resistance mutations, making it very difficult to come up with the second generation inhibitor that can get into that kinase domain and block the signal. But not only that, we're also seeing bypass mechanisms of resistance, particularly concentrated in the MAP kinase pathway that again is very difficult to drug if you have RET mutations and then say a BRAF V600E mutations. How can you give dabrafenib, trametinib, and selpercatinib to a patient? What we're planning on doing with her, as I said, because she's got oligoprogressive disease, which is the best kind of progression, I guess, that you can have, is removing the oligoprogressive site and then keeping her on the selpercatinib. I think that we may consider radiation based on the surgical findings as well.
That's fantastic, Dr. Wirth. I mean, for the ones of us that have been treating this disease for a long time, to have this case be stable for years and years is amazing, even though we knew from other oncology where we're going to see resistance develop. I think still an amazing story for her. So we'll finish there. I'll thank the panel, thank the team. Those are wonderful cases and wonderful teaching points. Thanks for putting it all together. Everybody have a wonderful week, and we'll see everybody at next week's thyroid meeting. Have a great day.
Thank you. Nice to see everyone. Bye-bye. Be well.